Hello, my name is Michael Byers, and I'm the chair of the Salt Spring Forum. And this is part of a COVID-19 series that the Salt Spring Forum is bringing to you in partnership with the Tyee. We have an absolutely fabulous guest this evening, Dr. Jane Philpott, former Federal Minister of Health and soon to be the Dean of Medicine at Queen's University in Kingston. And to moderate Dr. Philpott, we have Dr. Kevin Patterson, who many of you have seen before because he was our first guest in this series. Now he's in the moderating chair, asking the questions, including some questions from you. And Dr. Patterson brings a great deal of his own experience, including having worked during the COVID-19 crisis in the intensive care unit in Nanaimo. So without any further ado, I give you Dr. Jane Philpott and Dr. Kevin Patterson. Thank you.
Dr. Philpott, thanks for joining us tonight. It's a pleasure to meet you, if electronically, but I suppose that's how all our interactions are happening these days.
It seems to be, although I'd love to be out with you in the nicer climate that you have there.
It's a gentle situation. People walking around in shorts, and I think it's probably a little bit easier to endure the social distancing when it involves walking in the woods a lot rather than cooped up in the city. You've been spending quite a bit of time working in long-term care homes over the last few weeks. Is that correct?
Well, it's not actually a long-term care home. I've been helping out, spending most of my time helping out at a group home. It happens that the residents there are there long-term, but they're adults of all ages, from people in their 20s to people in their 70s, but they are adults with pretty serious intellectual and developmental disabilities. And it's a home that's had a very serious outbreak. There were 42 residents living in that home, and 40 of them developed COVID. It was a really difficult situation. So I stepped in to help there on Easter weekend, and I've been there most of the time since, although things are thankfully starting to get better.
That's interesting, because it really encapsulates the Canadian experience with COVID, isn't it? I mean, it's really been a long-term care home story nationally. BC's been relatively less hard hit, but even here, most of our cases are in long-term care homes. What is it about the Canadian situation where we seem to be uniquely vulnerable to the long-term care home vulnerability? Other countries haven't seen quite this degree of concentration in that community.
It's a really great question, Kevin. And I think certainly some countries have had similar issues, but Canada's been the one that has shown that contrast perhaps most starkly, not so much in the number of cases that have occurred in these congregate settings like long-term care and group homes, but particularly the number of deaths that have occurred. And as you know, depending on which province you're in, 70 or 80% of the deaths in Canada from COVID have been somehow associated with these long-term care facilities. I think there are a whole bunch of reasons, and obviously we've got more work to do in examining it, but a lot of it has to do with the way that some of them are designed, with people living in very close quarters. There are some pretty serious staffing issues around these homes often struggling to be able to maintain the number of staff that they need to provide good care. And in Canada, we really haven't done a great job at setting standards and regulating these facilities. Again, it varies a little bit from province to province, but in some cases, the regulations are pretty weak, and they're not necessarily getting regular check-ins to see that people are actually getting the kind of quality care that we would expect for our seniors and for vulnerable people.
Mm-hmm. It's early days, of course, and the data isn't all in, but some preliminary analyses suggest that the for-profit homes are more vulnerable, riskier places than the not-for-profit homes. Do you think that's going to be borne out by a closer examination of the data?
Well, I think it's an area that we really have to dig into, and you're absolutely right. There have been a few studies that have come out that are showing, certainly in Ontario, we're seeing that the higher number of deaths are taking place in the for-profit facilities. My understanding is that that's not the case in every province, but as you know, more and more of these long-term care facilities have been moving to a for-profit model. And as that happens, and as we start to see that there are some real risks associated with that, it's absolutely one of the areas that we need to be looking into. And I think this whole realm of seniors care, that Canada has a responsibility to do a pretty serious analysis of what's going on and to raise the bar. If we can't take care of the elderly, of our grandparents, of the people who built this country and laid the foundation that we're enjoying now, then it would be pretty shameful for us if we can't do better and try to protect seniors and others like the people at Participation House where I've been working.
Mm-hmm. Especially in an era of unprecedented affluence, until very recently.
That's for sure. And it's not a matter. It's not necessarily that this is a super expensive issue that we're dealing with. Of course, healthcare in general is expensive, but when you look at all of the other things that we're spending money on right now, it seems like in putting it in perspective, providing good quality care is surely something that's worth all of us bearing the cost of in order to care for the people who cared for us.
Mm-hmm. Just to back up a little bit from the long-term care home focus, I wonder if you could comment on how you think we've done nationally in terms of our response to the COVID outbreak. As Minister of Health, you must have been involved in pandemic preparation, especially after 2009 H1N1, 2003 SARS, and the Ebola concern, which never really manifested itself in Canada. Nevertheless, we had a number of warnings. It was a subject that was being discussed at the highest levels, I should think. How do you think we've done as the plan has rolled out compared to the expectations?
Well, all of these things look different in hindsight, and I don't think there's anybody who would say that we wouldn't do things differently, and any leader that wouldn't say that they would have been better prepared if they had known what was going to happen. I think you need to look at it in segments. We talked about the issue around care of seniors. That's sort of one whole area where there wasn't the kind of preparation that there should have been. There's the issue of how we've dealt with the pandemic from an economic perspective and the huge job losses and economic vulnerability that people are facing. But, I think your question is kind of getting at the public health piece, which is definitely an area where it's always been hard to encourage governments to invest in public health. That people don't want to spend the money on the ounce of prevention, even though we all in our heads know that it's worth a pound of cure. You look at the budget of the Public Health Agency of Canada, it's pretty modest. $675 million, I believe, is the annual budget, which sounds like a lot to people when they think about dollars. But if you compare that to other federal departments, it's a very modest, small department. We have, I would say, pretty simple, basic public health legislation in this country, not of the strength that it ought to be. We have some real challenges around what public health looks like from a federalism perspective. So, the data collection and the obligations of provinces and territories to share data so we can actually get a sense of what's going on. There are literally no federal tools to be able to oblige provinces right now to share that data. So there are a lot of things that we need to do better on. There are some of those things that I recall trying to push for, and it was hard, I have to say, to get attention for public health. And hopefully now one of the good things that will come out of this is we have to figure out how to strengthen those institutions of public health at every order of government in the country.
Mm-hmm. It looks like the World Health Organization needs some advocates and some friends right now. Will Canada play a part in that, do you think?
Oh, I think so. I mean, Canada's historically had a good positive relationship with the World Health Organization. It's not surprising that in circumstances like this that they will face some of the blame, but I think that blame has to be shared around in terms of advice that was given by the World Health Organization that wasn't necessarily taken up on by countries around the world. And again, the World Health Organization is actually functioning on a pretty modest budget in the scope of large international bodies of governance, and it has struggled to get that kind of support that it needs. So there's work to do to strengthen that organization for sure, but we can't necessarily say that it's all WHO's fault that things didn't shut down as quickly as they ought to have in those early days.
Mm-hmm. I wonder if we could talk for a moment about the vulnerability of Indigenous people in Canada. I've worked for about 25 years on the west coast of Hudson Bay and in the communities there. And as you know, tuberculosis exists in rates that are comparable to Somalia's as a consequence of having 23 adults in 3-bedroom houses. It seems to me like there is a potential catastrophe there, just waiting a spark. What ought we to be doing right now? What can we do right now to mitigate that vulnerability?
Kevin, I think that's such a good question, and it's an area where I hope there will be increasing focus, because what I believe has happened to date is that some of those communities have made really smart decisions and have worked really well to protect themselves, and have, to a certain extent, had some geographic advantages to be able to do so. What happens, though, in that situation is everybody lets their guard down. And as you said, when COVID gets into these communities, as it will, these are communities that have not had most of the, I think about the communities that I'm familiar with in northern parts of Ontario, Anishinaabe Aski Nation territory. They have, except for one community, not had a case of COVID yet. But you're right, when it gets into communities where you've got, several thousand people living in often crowded conditions, it will spread quickly. And so trying to protect those communities is a job that we're going to have to focus on collectively for at least the next 2 or 3 years, until hopefully someday we get a vaccine. But opening the gates wide, knowing that they don't have the health facilities that are necessary to be able to care for large numbers of sick individuals. There are some serious risks, and I know worked in the north as well. You talked about tuberculosis rates. The comorbidities of something like tuberculosis will make people at very, very high risk of a bad outcome. Mm-hmm.
Suppose we were to wake up tomorrow with dreadful news out of Red Sucker Lake, and clearly there needed to be a very aggressive intervention both in the community and in the receiving hospitals. Who has the resources to respond to that? Would it be the university? Would it be the military? Do you have thoughts about, if you were still Minister of Health, how would you be preparing for that day?
Well, I do think, as I said, that the geography has given some advantages. So I know in the early days, say middle of March, when you looked at across First Nations communities, for instance, in remote parts of the country, very few of them had adequate amounts of personal protective equipment, swabs, and all of the things that health facilities in cities will have. That's one thing that I do think has been scaled up relatively well. But what you're referring to is what is going to happen when you suddenly get, 5, 10, 20 sick people. and there's only a little nursing station. There's not actually a hospital there. That's where there are going to be big challenges, where the military will have to be one of the possibilities. I know the Canadian Red Cross has actually been working very closely with some communities, preparing for the possibility to be able to send in field hospitals. And we may see some kinds of things happen yet. It's a little tricky to do because you can't put a field hospital in every small remote community in the country. So to a certain extent, you do have to wait and see what's going to happen, but you have to be ready to deploy very, very quickly and make sure there's also a roster of health professionals that can go and help. And so I do think we will be counting on some of these non-governmental organizations to be able to work with communities, and hopefully that can be done in a way that is highly respectful of the rights and of Indigenous peoples who need to be in the driver's seat in terms of how all of this unfolds.
Mm-hmm. I think Médecins Sans Frontières has sent a team to the Navajo Nation in America, where I think we're getting a little augury of what might wait us with terrible tempers.
MSF has certainly been involved in conversations in Canada too, and I haven't been closely tied into some of that, but I know that there have been good conversations with them, with Canadian Red Cross. Obviously, Indigenous Services Canada is very intimately acquainted with that, and I think there are pretty good preparations in place, but we have not yet seen, I think, the serious implications of what's going to happen if in fact the virus spreads to places like that.
Mm-hmm. I wonder if we could turn to some of the questions that Salt Springers have prepared for you. And this is from Theron Gower. Much of the anxiety around the pandemic seems to focus on the lack of readily available tests. How important is testing as a way of preventing transmission of the disease?
Testing is absolutely essential, and we will not be able to fully open up the economy and get life back to whatever our new normal is going to be until there's widespread testing. And Canada is still well back of the lead in terms of how well we have done at this. The date that you and I are taping this, which is the middle of May, there was a really excellent article by Andre Picard in the Globe and Mail that talks about testing, and hope people should read that if they're listening to this in close proximity to the middle of May. But he compares Canada to how other countries are doing around the world, and you'll see how far back we are. There has not been the ambitious emphasis on testing that there ought to be, and then there's a whole mess of other problems around people getting their results fast enough. And even if you get a positive test, what's the contact tracing been like? And I'm sure the people that you've talked to are similar to the people that I've talked to on the ground. Maybe BC's probably doing a little bit better because your numbers are looking really, really quite positive or quite hopeful at the moment, and the number of cases is smaller. So contact tracing inevitably is perhaps not such a monumental task, but certainly here in Ontario, we're hearing lots of situations where public health officials just cannot keep up with the contact tracing necessity, and in some cases it's not being done at all. And getting control over the epidemic and the outbreaks will not happen without huge availability of testing.
Some pretty big hurdles there. Linda Miller writes, what can you tell us about the health consequences for the thousands of people who are reported as recovered cases of COVID-19? Are there serious conditions that have resulted from the infection or the treatment?
Well, as you would know, Kevin, we're still learning a lot about this virus. And I think every week that rolls by, we learn more about the kinds of additional medical outcomes that happen. One of the latest ones being the emergence of high numbers of cases of Kawasaki syndrome in children. Lots of case reports of other types of inflammatory conditions that the virus is causing. So I don't think we know enough to answer that question really well yet. What will the outlook be like for people who have been infected? Will they develop immunity? Will that immunity be lasting? It's still unfortunately too early to be able to answer all of those questions well. Obviously, everybody's hopeful that a single infection will confer that kind of immunity and that there won't be lasting consequences. But certainly there's some indication that for some individuals there may be longer term sequelae, and some people are taking a longer than average time in order to fully recover from the illness.
Thank you. Here's another one that recapitulates some of our conversation. This is from George Williams in Morristown, BC. Nunavut has had no cases of COVID-19. Here in the BC Northern Health Region, we've had no deaths and the number of positive tests is low. Yet we hear that Indigenous communities are especially vulnerable. Can you help us understand what is going on?
Well, I think there are multiple things that are going on. I talked earlier about geography, and when travel gets shut down, it can, for the short term, be able to protect some communities from having less traffic moving in and out, making sure that there are rigid protocols for people that move in and out of more remote communities. I think in some cases it's a sign of really good public health institutions. I think, you guys are pretty lucky out there in BC. You've got a fantastic chief medical officer of health who I think has probably helped make some smart decisions and probably working alongside groups like the First Nations Health Authority to be able to provide some of that protection for their communities. But the reason that we're talking about the vulnerability and the risk is the things that you and I talked about earlier. I don't know how many Canadians are aware of the kind of statistics that you referred to around tuberculosis. Amongst Inuit living in Nunavut, the rates of tuberculosis are 300 times the rate in the Canadian-born non-Indigenous population. And an outbreak of COVID in community in Nunavut is going to be highly lethal, and let's just hope it doesn't happen in the near future. And I hope that officials will be very, very cautious about reopening travel into the territories and into the north.
Mm-hmm. Frank Blister from Regina writes, there are some deadly viruses, such as HIV, which have been around for decades without any success in developing a vaccine. Is this a possibility with respect to COVID-19? And how could anything return to normal if we never have a vaccine?
That's a depressing question, isn't it?
Yes.
Well, I'm not a virologist. I don't think you are either, so I don't want to get too far into speculating on things that are not my area of expertise. But it's a really good question because the person who provided the question is absolutely right that HIV has eluded an extraordinary amount of emphasis on trying to develop a vaccine. Now, thankfully, in the meantime, triple therapy has meant that even though it can't be cured, that it can be managed, and it is no longer the severe life-threatening infection that it once was. But hopefully, again, we will get a vaccine for that one of these days. I think there's some hopes that the viral properties of this particular coronavirus will lend itself more easily to be able to develop a vaccine. But will we be able to get back to normal without a vaccine? Could be here with us to say. I mean, I think most now would speculate that the virus is here to stay regardless of whether or not we develop a vaccine, that the possibility of eradication is beyond our reach at this point. But the combination of a vaccine and growing percentage of people who have built immunity is, either of those we're talking years before we get there.
Thanks. Here's our final question. This is from Anonymous. You are about to become Dean of Medicine at Queen's University. How do you think the collective learning experience of this pandemic will shape the future of medical education in Canada?
What a great question. Well, you're absolutely right. I'm very excited that I'm starting in July going to be Dean of the Faculty of Health Sciences at Queen's. So I will have responsibility over the School of Medicine as well as the School of Nursing and the School of Rehabilitation Therapy. This has changed the way that we're going to teach. It's changed what people need to learn, hopefully in many positive ways. I think you and I know how much work needs to be done on making sure that our health professionals of the future really understand the role of the social determinants of health. And this is a virus that has once again laid that bare to us in terms of looking at who's vulnerable. It's not all biomedicine that health professionals need to know. They need to understand the social sciences. They need to understand that when people don't have housing or live in crowded housing conditions, that they are more likely to have a bad outcome from a virus like this. So I think this is also hopefully going to really help us do better at teaching both public health and population health, which certainly in my days of going to medical school were a pretty tiny part of the curriculum. And I think that medical schools, nursing schools, et cetera, across the country are going to realize that portion of our curriculum needs to be greatly amplified.
Great. We actually have time for a few more questions.
Okay.
Gail McCormick from Perth writes, why won't Canada and the provinces take the needed actions and financial investments into proper, dignified, long-term care for our most vulnerable and frail citizens? Wouldn't improving care for those most in need also improve the lives of the many people, women and minorities, working in these facilities?
So that is a really good question. And I think, again, this is one of the areas where I hope we'll see dramatic changes in Canada. I think we need to do two things pretty quickly as a country, and I think hopefully most orders of government will look at this, and that's to look at everyone's looking at the economic picture. You don't have to convince governments that they have to look at their economy. That's a singular focus for most leaders. But the other two pieces that I talked about earlier, the public health piece and the seniors care piece, they need to be at least as much of an emphasis of our governments to be able to focus on those. So this question, a whole issue around seniors care, is something that has not been a priority for most governments. I'm hearing, I've had a couple of interesting conversations with elected officials recently around the idea of a royal commission, and royal commissions don't always mean things change, but let's put a big emphasis on saying, how can we do better? We're all proud of the Canada Health Act and how it means that we've got universal publicly funded health care, that people get access to care based on need and not based on their ability to pay. But that actually doesn't translate into seniors care. We can't say that when you become elderly and disabled perhaps by dementia or something else, that you will get access to a great care facility based on that need, not based on your ability to pay. People who can pay more are more likely to get to the front of the line in the facility that they can afford. And as I say, I think there's a lot that needs to be done around setting some kind of national standards. In many places in the country, and I'm not sure of the regulations in British Columbia, for example, but in some provinces, the regulations only require that you would have one nurse caring, no matter how big your long-term care home is. Imagine that you had 150 seniors, many of them with very serious medical conditions, and you only have one nurse in the entire facility. The rest are lesser paid, unregulated staff that are working to be able to provide that care. It's disrespectful, and we have really not turned our attention to it, and this virus has forced us to do that. And I hope that there's not a public official in the country that doesn't believe that they have a part to play in doing better.
This is from Wendell Singh in Surrey. COVID-19 has reached the global south, where healthcare systems are often inadequate and poor, cramped neighborhoods are common. Then there are the camps for refugees and internally displaced people, housing many millions. Is the worst of this pandemic still to come? What can we in Canada do to help?
Well, that's a really important question as well. And I would have to say, first of all, yes, the worst of this pandemic is still to come. I wish that were not the case, but I think that's a fairly safe prediction that, in particular for the global south, this is going to get much worse yet. The circumstances are not dissimilar to what you and I talked about earlier related to Indigenous communities, where there is less travel to certain parts of the global south, and therefore it has delayed the spread of the virus into certain regions. And some regions just seem to be more susceptible than others for reasons that we don't yet entirely understand. But I think that your questioner really hit the nail on the head in terms of talking about what health systems are like. And, I've spent a good part of my life working in sub-Saharan Africa, and the issues around the lack of health professionals, doctors. There's an article in BBC or somewhere yesterday that talked about the fact there's only one respiratory therapist in the entire country of Ethiopia. Some 80 or 90 million people living in Ethiopia now, and one respiratory therapist. Not to mention lack of the kinds of facilities that are necessary to take care of critically ill individuals. So this will hit hard. And again, hopefully there will be as much delay as possible to prevent the spread of the virus into vulnerable communities and countries that have struggling health systems. But, it will eventually hit communities, already is, but there are some pretty tough days ahead.
Thank you. Arthur Gage from Port Moody writes, mental health is emerging as a major issue during the pandemic, with life-threatening consequences, for example, domestic violence. Yet mental health care has been woefully underfunded for decades in BC and presumably in other provinces. How do you think this country can address mental health properly? Is it just a question of funding, or is a change in perspective also required?
Well, that's a good question, and I'd love to have a conversation with the person who asked around the change of perspective and what exactly is implied by that. But that's an interesting way of asking. It's not just funding. I think that your questioner brings up the point that yes, of course, we need better funding for mental health care, but the way that we set up systems of mental health care, who provides it, whether it's part of publicly funded systems or not, are all really important questions. As a family doctor, I certainly often struggled with the fact that if people had a healthcare plan and could go on prescription medication, that we often, as physicians, move to medical or pharmaceutical treatments because of the fact that we could find ways within our public health system to be able to provide people with the kind of counseling or talk therapy that they need, depending on what the mental health condition happens to be. So changing the availability of support for social workers, psychologists, and many other health professionals who are really great at providing mental health care is one of the things that we need to do to set systems differently. But as it relates to COVID, that will be the next really bad wave for us in Canada. I mean, I think people, I think about the people who I've been working with at this group home, and, you know, we've dealt with horrible grief. 6 of the residents died, and the nurses that work there said to me they've literally had to put their emotions in a box because they couldn't grieve. We had to just keep going. We had to make sure that nobody else died. And people have kind of set aside that emotional pain that they have to work through, but you can't set it aside forever. And there will be a tremendous amount of post-traumatic stress related to what people have gone through, not to mention the kind of stress that people are going to deal with because of their economic fragility that this pandemic has exposed. And it's going to take a long time for us to rebuild ourselves and our mental wellness.
Becca Verity from Vancouver writes, "You have said that you entered politics to help make positive change occur on a larger scale. Were you right to think that this was possible? Knowing what you do now, would you do it again?"
Those are great questions. Absolutely, politics is a place where you can make positive change. It's really hard work. And you know, there are lots of frustrations along the way. I certainly don't regret the experience of having been involved in politics. I really encourage people of all walks of life and all vocational backgrounds to consider stepping up for public office, because we need a much greater diversity of people involved in public office, people that are there for the right reasons. So I don't regret it. I absolutely believe that it can be a great force for good. Unfortunately, it can also be a force for things that aren't so good. But if you go into politics for the reasons of trying to improve people's lives, there are always ways that you can do that. And as I say, I really encourage people to consider it for themselves.
Thank you. This is a question from Anonymous. In terms of addressing the causes of zoonotic diseases and mitigating the risk of future pandemics, should we consider industrial animal agriculture as a public health issue in Canada?
Again, this would be an area that I would not consider my area of expertise, but I think it is something that we do need to have a stronger focus on in Canada, but even more so looking at the entire food supply chain, the entire global relationship between things like the kinds of markets that this particular virus has been traced back to, that these are the kinds of things that a place like the World Health Organization, for example, needs to be placing some of its focus for further study and recommendations, because so many of the very serious viruses that we've encountered over the last generation have had their roots in some of these very animal populations, and to a certain extent may have been preventable as a result.
Thank you. This is from Brian E. Penn, pardon me. Why are the construction workers, pipeline workers, loggers, and other resource workers considered essential services? It seems that the conditions at the man camps and work sites put workers at unavoidable risk, and the communities to which they return are often small, rural, and northern places that can least afford these risks.
Well, I'm not sure of the entire background to this person's question, because I think what's happened in the country is that the rules around who are essential workers is varying a little bit from province to province. But the questioner does raise a good issue in terms of the fact that anybody who's declared an essential worker takes on risk not only for themselves, but they take on risk for their family members, and they take on risk for their home communities. And, this is not COVID is not unique in this. We were talking earlier about HIV, and we certainly saw these same kinds of phenomena that were associated with the spread of HIV in communities in sub-Saharan Africa, for example, where people would acquire the infection working in mines and then take it home to their families in more remote communities. So this is a chronic challenge that societies have to deal with in terms of how diseases are spread and the role of the workplace. I would say one of the things I think we need to learn as a result of this is that the focus for trying to contain and control the virus needs to be very much workplace focused, and looking at some of these high risk workplaces as where we should be focusing our massive testing facilities to be sure that it's safe and that viruses are not spreading.
And that concludes our conversation. Thank you so much. It's been lovely talking to you.
Well, thank you. You had some pretty tough questions there for me, but it's been good to have a conversation, and it's been nice to have time together.
Great. Thank you, Dr. Philpott.
Okay, thank you.